Okay, well, I may as well start talking. We're at the top of the hour. Everybody, welcome back to the AOMA Summit for our last session, which should be the next hour. And just a reminder regarding donations for ocular melanoma research can be made through the link in the chat box or the QR code that has been shown at various times. And thank you very much for all those people who have donated so far. To close, we've got two great speakers. So to start with, a very close colleague of mine, Dr. Joseph Sacco, who's very kindly to wake up early on a Saturday morning and talk to us from the UK. So Dr. Sacco is a reader and honorary consultant at the University of Liverpool and the Clatterbridge Cancer Centre. He is the UK lead for the Uveal Melanoma International Rare Cancers Initiative, ERCI Initiative, and the Omni Registry. And he's been involved integrally in the clinical development of tebentafusp and is an investigator on the FOCUS clinical trial of percutaneous hepatic effusion, which we heard briefly about this morning, as well as the RP2 trial, which maybe he'll tell us about today. And I'll just hand over, Dr. Sacco, to you. Thank you very much for taking the time.
Thanks, Anthony. And I will just start sharing. Thank you so much for the invitation. It's a pleasure to be here. And a good afternoon to everybody, and morning for anybody who's like myself in a different time zone. So I'm going to talk today about liver-directed therapy. Okay, let me see if I can move the slides. It's always a good start. These are my disclosures. So I kind of wanted to use the opportunity to very briefly touch on the history behind some of the progress in liver-directed therapy and how it's got a long history, but use has been variable, with access in particular being very patchy. But my hope that with the results from the FOCUS trial recently, that this will change and drive more equitable access across the globe, as well as then pointing the way towards expanding and augmenting from this in terms of systemic therapy effects as well. Apologies. Uveal melanoma, as many of you will know, is highly hepatotropic. So it almost always goes to the liver as the first site of metastasis. And even after years, it can remain just in the liver, particularly if it's treated there. In a proportion of patients, that changes and it spreads elsewhere, but some, as I say, continues to be very liver-driven. In a small proportion of patients, around 10 to 15%, who are undergoing surveillance, we can use local liver treatment approaches such as surgery or ablation to remove oligometastatic disease. So this is, one or two metastases, maybe three or four, depending on location. And this has been associated with prolonged disease-free interval. Not cure, but at least it gains control for some time. With more extensive disease, treatment of more or all of the liver is required. So if it's got more miliary pattern or multiple mets in bilobar distribution. And this over time has employed infusion of chemotherapy, radiotherapy beads, but also bland embolization, immunoembolization, etc. And it is fair to say that investigation in the area has had its ups and downs. This is an example of one of the very few large studies, which was randomized study of photomustine given either IV or hepatic arterial infusion. And despite the prelim data, in other words, smaller trials beforehand had shown significant promise, there was really no benefit in this approach compared to IV with a 2.4% response rate. On the other hand, there have been a number of single center studies, particularly I will come to mention the group in Jefferson, which have shown promising results, while a meta-analysis of clinical trials in uveal melanoma suggested PFS and OS was better with liver-directed therapy, although it's always important to take into account that these are driven in part by selection bias because it requires that the disease is still confined to the liver and not more extensive. One of the approaches that has gained considerable traction over the years is called isolated hepatic perfusion. And the chemotherapy that was used with this is melphalan. The technique itself was first used over 60 years ago, and the phase 1 and 2 trial published in 2000 showed a response rate of 62% in uveal melanoma, so really high considering how difficult this cancer can be to treat. However, it requires laparotomy, extensive dissection, and is a one-time technique, which has limited uptake, although a few centers have continued to use with success, and I'll come back to that in a little bit of time. But it has also led to the development of an alternative way of delivering very high-dose chemotherapy into the liver, percutaneous hepatic perfusion with melphalan, which is also known as Hepzato KIT, and has been developed by Delcath. So this system involves catheterization of major arteries and veins, as you can see here in the rather complicated diagram. The blood is fed into the liver basically with melphalan at a very high dose, and then in the outflow goes through a filter which removes the vast majority of the melphalan, allowing the blood to be returned into the circulation without melphalan, and you have orders of magnitude higher delivery of chemotherapy into the liver at a dose that you wouldn't be able to do with systemic treatment, and with much lower side effects as a consequence. Importantly, the treatment can also be repeated. And it has a long history as well, and this is a study that was published in 2015, an early randomized phase 3 study, which showed quite significant improvement in hepatic and overall progression-free survival, although there was no overall survival benefit as a whole. And this was very likely driven by crossover, at least in part, which was allowed on the study. It was reviewed by the FDA, did not approve it at the time because of the lack of overall survival, but also because initially there were mortalities associated with this. Although with next generation filter, the safety has been improved significantly, as well as with a very rigorous mentoring process. It was, however, approved by the EMA as a device, and therefore has had certain countries that have been able to deliver it more widely, including in Germany. And in the UK, it's been used quite a lot in Southampton, although this has mostly been covered privately and not by the health system. The company then, to their credit, went back and started a second study called the FOCUS trial, which was a randomized trial with eligible patients with hepatic dominant uveal melanoma, randomized 1-to-1 to receive PHP or best alternative care, which could be chemoembolization, pembrolizumab, ipilimumab, or dacarbazine. It was a difficult study, and this is often the case when you've got very differing arms. In other words, one of them being a sort of systemic arm, the best alternative care, whereas the other one is the intensive PHP approach. As a consequence, the trial design was amended to single arms design with all eligible patients receiving PHP, and this was after discussion with the FDA. PHP could be up to 6 treatments in total at an interval of 6 to 8 weeks, and patients with hepatic or extrahepatic progressive disease were discontinued from study treatment but followed until death. Patients were imaged every 12 weeks or so, and the primary endpoints are shown here, driven as primary endpoint was objective response rate. Okay, see if I can get it to move. So both overall response rate and disease control were significantly higher in the PHP arm. A total of 144 patients were enrolled overall, with 102 assigned to PHP and the remainder assigned to the back arm. Of those 102, 91 received the treatment as allocated in the PHP arm, and 32 received back. This is the waterfall plot. On the left-hand side, you can see that for PHP, and on the right-hand side, you can see the waterfall plot for the best alternative care. And you can see then the response rate of 12.5% with the control arm versus 36.3%, which was statistically significant at 0.0117. The next slide shows the median PFS, which was also significantly improved in patients who had PHP as compared to alternative care. In terms of overall survival, this was not statistically significant, but did show a numerical improvement of around 6 months compared to the alternative care. Of the patients who were on the PHP arm, 37 received the maximum 6 cycles with a median number of 4. And of those who were assessed for safety, in other words, who'd had PHP, 42.6% of patients received a serious treatment of emergent adverse event, but the majority of these were hematological, transient in nature, and resolved without sequelae, and there were no treatment deaths associated with it. The side effects are summarized here. So in addition to the phase 3 trial, there's now been several series that have been published, which show the efficacy, which mirror the efficacy seen in focus study, e.g. Modi et al. That's a series from Southampton. And we know that repeated courses of treatment are feasible with response and subsequent exposure. Anecdotally, I have a patient who received 10 treatments with PHP in total over about 4 years and had really good responses to treatment on both second and third time, but first and second time, although the third had toxicity and melphalan allergy. And as of August 2023, PHP with melphalan is now licensed by the FDA with an increasing number of centers in setting up. Treatment does require a multidisciplinary approach with interventional radiology, anesthetics, perfusionists, and careful perioperative care, which means that there is a steep learning curve. But with experience, requirements for post-procedural care and monitoring can be significantly reduced. So the team in Southampton, which have one of the longest kind of involvement in PHP, now just send the patient to post sort of op recovery area, and after that straight to the ward with an average sort of 2 to 3 day admission. So despite this complexity in delivery, it is relatively well tolerated, and the side effects are almost always transient. I think something to remember is that this is, once every 6 weeks or to 8 weeks over 3 to 4 treatments, often on average, maybe a little bit more. So as compared to something where you keep on delivering treatment, the side effects can be cumulatively less of an effect on quality of life. So how about IHP? As I said, I would go back to that. In the Scandinavian countries, and this has continued to be used quite widely. And the Scandium trial is just reported in the last couple of years. This was a randomized multi-center trial, which was similar to the kind of design of focus. So it was randomized to IHP or best alternative care with no crossover allowed. The primary endpoint was overall survival at 24 months, and secondary endpoint was response, PFS, safety, and quality of life, with 90 patients overall enrolled. The response rates are shown here. So 40% for IHP as compared to 4.5% for control. And again, some deep and durable, deep responses seen on the right-hand side here. This didn't quite translate into overall survival. So the IHP had a median survival of 21.4 months with the median and the control of 17.3, and that the p-value is 0.23. Dr. Olafsson-Bagge has also done a lot of work around a meta-analysis to really compare IHP and PHP. And this was published a couple of years ago with 128 patients on IHP and 164 patients on PHP. And from a median overall survival advantage, there's no statistical significance, with quite close tracking early on. Now, just in terms of speculation, the latter difference that you can see numerically may be driven by the fact that you can't repeat treatment with IHP, although obviously that's very much speculative. In terms of complications, there was a significantly higher proportion of severe surgical complications after IHP and a higher 30-day mortality. So to end this section, I would say that the feeling was from investigators with IHP that although the outcomes kind of support the high doses of melphalan into the liver, the delivery of this is more complicated and has higher toxicity, thus leading the Scandium investigators to look towards PHP as well. And then, so what next generally with PHP and IHP? I think this is really around combination with systemic therapy and trying to drive a longer, more durable response, and hopefully see if we can actually get more of the immune component to kick in. And the Chopin study has published its phase 1b element. This is a combination of ipilimumab, 1 milligram per kilogram, and nivolumab at 1 or 3 milligrams per kilogram with PHP. 7 patients were recruited into this element of the trial, and both dose levels were considered to be tolerable, with 1 CR, 5 PRs, and 1 stable disease. As you can see, the spider plot is very impressive here. But I think it's really important that this is only 7 patients, and we need randomization to confirm this efficacy. The investigators are well aware of this and are now looking at, I think they're now recruiting to a randomized element of the study, which aims for 76 patients in total. Scandium-2 is also looking at the combination of ipi/nivo with IHP. And this study has shown results, I should say, it looks at 2 different approaches, a sort of adjuvant approach and a neoadjuvant approach, with the adjuvant IHP first and the neoadjuvant ipi/nivo first. The outcomes for this show the progression-free survival was numerically better with the adjuvant approach than the neoadjuvant approach. In other words, IHP first. Survival looks similar, and I would just highlight that the median of 18.2 months or 17.2 months is not dissimilar from single agent IHP or PHP. So again, really highlighting the need to see what this is in randomized trials. Other approaches to combination with immunomodulators include in this trial that is in setup at the Jefferson. Takami Sato and Malana Orlov have both been really involved in driving liver-directed therapies with various immunoembolization, chemoembolization approaches, which have in single-arm studies shown significant response rates and PFS. But here they're looking to use tebentafusp, which, as you will know, has shown survival advantage in uveal melanoma in combination with immunoembolization, hopefully gaining benefit from both approaches. This is still in setup and hasn't yet started enrollment. And then something that Anthony touched on earlier about RP2, which I don't know if it's strictly a liver-directed therapy, although in most patients in uveal melanoma, it ends up being so because that's where most of the metastases are. But I thought I'd just mention what oncolytic viruses are. And this has really started off in the field with TVEC, an engineered herpes simplex virus, which was the first oncolytic virus to be licensed. And the idea here is that you get local effects. You inject the virus into the tumor, and then it leads to cell death in the tumor itself. This leads to the recruitment of T cells and activation of the immune cell locally. And I think of this like an in situ vaccination. So it's a very personalized vaccine because we're using the tumor itself to vaccinate against the tumor. But instead of taking the tumor out and deriving a vaccine, we're doing it there. We're driving the vaccination in the tumor itself. And this then leads to activation of dendritic cells and the downstream to the CD4s and CD8 cells, which then can travel to uninjected tumors and drive response. And in a study a few years ago called TVEC 325, we showed that uninjected lesions, shown here in this panel, had a significant infiltration in T cells as a consequence of injection distantly. So really showing that we can drive that abscopal effect, at least from a biological point of view. Now, Replimune are a company that have sort of worked from this basis to try and derive further benefit. Because one of the problems with TVEC has been that the sort of visceral abscopal effect is very minimal. In other words, if you inject a lesion on the skin, for example, we don't see much in the way of response in visceral lesions. So they started off by screening a whole stack of different isolates of herpes simplex to find the most potent version of this that they could then engineer. And in the first instance, they put in a GM-CSF gene as well as a fusogenic protein to drive immunogenic cell death. And this was called RP1 essentially. And in RP2, which I'm going to discuss further, they additionally added an anti-CTLA-4 antibody-like molecule. So really trying to drive that immune response locally, but without hopefully the distant effects of ipilimumab. And this is the study design. So it has components of monotherapy, one agent, just with RP2, and then combination with nivolumab in the cohorts 2A and 2B. And RP2 is administered via direct intratumoral injection, either into the superficial lesions under direct visualization or palpation, or deep visceral lesions using image guidance. And this included uveal melanoma in the eligibility, and we sort of ramped up a cohort of patients within that. And our primary endpoints were safety, tolerability, and overall response rate, as shown here with other secondaries listed. Uveal melanoma patient population is shown here just to highlight that the majority of patients had received both prior anti-PD-1 and anti-CTLA-4 therapy. In terms of response rate, for single agent RP2, we had 1 out of 3 responding, with a further 4 out of 14 in the combination, giving a total response rate of 30% in this case, and a durable control rate of around 60%. The responses didn't seem to be altered by whether patients had HLA-A0201 positive or negative alleles. This is the swimmer's plot, and you can see that the responses were often durable, as shown in the yellow here. We found quite striking abscopal effects. In other words, patients who'd been injected in one lesion showing response elsewhere. So this is a patient who had liver metastases that progressed on ipi-nivo and then received RP2 monotherapy, so not in combination. The red circle showing the injected lesion responding over time, and then the yellow circles showing non-injected lesions. We similarly had a patient who had progression on ipi-nivo, who then received RP2 plus nivolumab, and these are the scans at screening and then at 20 months. And again, you can see very significant response in the injected lesions, but also in the uninjected lesions. We were also able to show in a proportion of patients where we had evaluable biopsies that we were driving an increase in the expression of PD-L1 as well as infiltration with CD8 cells, and also that we were showing PBMC expansion, or rather T-cell expansion, with new clones identified at day 43 in the circulation. This didn't correlate with clinical response, however. In regards to the safety, the most common grade 1 or 2 TRAEs were in both cohorts were pyrexia, chills, fatigue, hypertension, and pruritus, which are really related to the virus response. There were a couple of episodes of grade 3 hypertension, but they were transient and readily managed with crystalloid replacement. No grade 4 or 5 TRAEs. And importantly, in patients who underwent intrahepatic injections, which were the majority of these patients, there were no clinically significant bleeding events. So just to summarize briefly, RP2 monotherapy, RP2 plus nivo resulted in a response rate of almost 30%, disease control rate of around 60% in the patients with metastatic uveal melanoma. Clinical activity was seen regardless of HLA status or specific prior ICI regimen, and both hepatic and extrahepatic metastases responded. Replimune are now starting a pivotal study which will be a randomized study, hopefully leading with registrational intent. So then I just wanted to end up with another really interesting approach that's underway. This is a trial of SD101 with immune checkpoint inhibition in metastatic uveal melanoma. So this is the PERIO-01 phase 1 study, and these are the results that were presented last year at SITC by Sapna Patel. So the idea behind this is that within the liver, we have within the liver metastases, there's a high pressure environment due to both the intrahepatic and intratumoral pressure. And this is a mechanical barrier that really limits efficient delivery into the tumor itself, either intravenously or through regional hepatic infusion. And secondly, the myelosuppressive environment within the tumor, which, as we know, is a significant issue with uveal melanoma. So in the PERIO-01 study, the investigators have used two sort of strategies related to this. The first is in terms of drug delivery, is using this pressure-enabled drug delivery system, which is a catheter system, but uses higher pressures, and in preclinical data suggests that you can drive more drug delivery into the tumor. In addition, they've then used a toll-like receptor 9 agonist to drive MDSC depletion and T-cell recruitment and activation. Notably, that there is the potential that there's an optimal dose for this that may be lower than the maximum tolerated dose, and I'll come to that in a second. There have been 3 cohorts that have been investigated to date. One is single agent dose escalation, and then dose escalation with anti-PD-1, as well as then with anti-PD-1 and CTLA-4. And the regimen included a sort of induction with weekly treatments for 3, and then an off period, and then repeated along with checkpoint inhibitor if in that cohort. So in across all of the doses, they saw a 60% disease control rate with some delayed responses, and notably an 81% disease control rate at 2 milligrams. But not partial responses. However, what's really striking is they had a very significant reduction in ctDNA, and indeed a sort of 60% ctDNA clearance in the study, with the 2 milligram plus Nivo dose showing 5 of 7 with greater than 50% reduction in ctDNA. And we know from experience in TEBI that this is a very important surrogate. And that overall survival may not be directly related to partial response. This swimmer's plot also shows the durable progression-free survival and control in patients on the study. In terms of overall survival, this is quite early data, but in particular highlighting the dose cohort with 2 milligrams of the toll-like receptor agonist, where the 1-year overall survival was 86%. And the feeling from the investigators is this is the optimal dose. The higher doses are not associated with better outcome. And just to summarize that, there is a reduction in Tregs, a reduction in MDSCs within the liver metastases in the data they've done, as well as a median PFS of 11.7 months, 1-year overall survival of 86%, with ctDNA reduction in 5 of 7, and no grade 3 or 4 TRAEs. So I think SD101 via pressure-enabled drug delivery plus immune checkpoint inhibitor shows promising activity in metastatic uveal melanoma, and further results are eagerly awaited. So then, just turning to my final thoughts, so the topic I'd chosen about focus being the end of the beginning is really because I feel LDT has a lot of promise, and the problem has often been about access, and which is very patchy, with some institutions doing a lot and others doing none and not having access. We in the UK remain, even with the results of PHP, going to be a struggle to get hold of this for patients. but hopefully at least the license of FDA will lead to this broader access and drive the field's acceptance of it as a whole. The combination of PHP and other LDT with systemic therapies, and particularly immunotherapy, may well extend efficacy, although further randomized data is needed. And then the novel approaches to LDT, where we're using agents that not only kill kill tumor where injected, but also drive that immune response, I think are very promising, but we obviously need randomized studies as well. So we're back to where one of the big challenges in uveal melanoma, which is really driving collaboration and trying to make sure that as a community, we select trials carefully to work together to deliver, but also the use of real world data. And I know Anthony's talking or has talked about the registry's efforts before, which I think are vital in this environment. So thank you so much for listening, and I hope that has hung together to some degree at least.
Thanks very much, Joe. That was very exciting and certainly very topical and up to date. Certainly brought me up to date with a few of the topics. I'm sure very much from everyone in the audience. So if you have any questions, Q&A chat. So next talk we have is from Georgia Hall. So melanoma, she underwent ice-bearing plaque radiation therapy and now diligently follows a scanning protocol. Beyond her personal journey, Georgia is dedicated to raising awareness about eye cancers, serving as the Australasian ambassador to the Victoria Cohen Eye Cancer Charitable Trust since 2022. And this charity avoids scholarships to aspiring ocular oncologists to support their training and educational needs. Georgia, I will hand over to you. Thank you very much for taking time to speak with us today.
Thank you. Thank you, Professor Joshua and Merin, for organising this wonderful summit. I'm just going to share my screen. Give me 1 second. Hopefully you can see these slides. Can you see them? Great. Okay, so my name is Georgia. It's lovely to join you all here. I was diagnosed with choroidal melanoma in 2021 when I was 31 years old. I have no history of cancer in my family at all. It was during the COVID lockdowns that I noticed a flash in the top right-hand side of my eye. And initially I thought it was some kind of migraine, and progressively over a course of a few days, the flashes became more like arcs. And then I noticed a black shadow over my eye, and I went to Specsavers. They referred me to Sydney Eye Hospital, and I was seen by an ocular oncologist the following week who diagnosed me with choroidal melanoma. It was a T2A posterior, so it was small to medium size, so 10 millimeters by 5 millimeters, not tiny, not large, sort of somewhere in the lower quadrants. To say it was a hard time, I think, is probably an understatement. The diagnosis hit me like a freight train. I felt incredibly lonely when I received the diagnosis. It really shook me, and I think the overriding feeling that I had was one of loneliness. As someone being diagnosed at around half the average age of the average person who has ocular melanoma, which is around 60 years old, I felt that I had my whole life ahead of me, and now suddenly everything was being put into question. I don't have any of the risk characteristics. I am dark-haired, I have olive skin, I have brown eyes. I've always been sun adverse. I don't like sunbathing. So who knows what caused it. I was treated with ruthenium plaque at Sydney Eye Hospital, and that was during the COVID lockdowns. So sadly, I couldn't have any visitors at the time. 2021 was a particularly difficult year for me because I also was treated, had decompression surgery for cauda equina syndrome, and then underwent reconstructive surgery on my lumbar spine, all within the space of about 16 months. So there's a picture of me on the left-hand side looking really out of it. I'll just move on. So the question really from there on was whether to biopsy or not to biopsy. It's not really from what I understand, it's not standard practice in countries like the UK or Australia. I know that in the US, it is more standard practice and is typically done at the time of the plaque placement. And in the UK and Australia, there is also the option to do the biopsy within a short window after the plaque treatment. I discussed the upsides and downsides of the biopsy with my ocular oncologist. The upsides being that it would give more information about the nature of the tumor. It might include me or exclude me from trials in the future, which is a good thing because I don't want to go into a trial without obviously making sure that it is really going to have a benefit. And also with the medical space changing so quickly on ocular melanoma, as we've heard all throughout these sessions, being so young at this stage, what if in 10 years' time, the findings of that initial biopsy could create more options for adjuvant treatments? I'm not sure. The downsides are, of course, as everyone knows, there is a very, very tiny risk of seeding. There's damage to the eye, but to be honest with you, I didn't really care so much about damage to the eye. I just wanted to have the best chances of survival. And then there are other downsides like risk of hemorrhage and so on. The other thing that was a big factor for me was whether the sample would really be accurate, because as we all know, tumors are heterogeneous. They are not, you can take a very small sample from one part of the tumor and it might be different to another part. And also sometimes you can't get a big enough sample that would render a sufficient amount of detail to give you those results. Either way, I opted for a biopsy and I decided to go for it. And I had a transvitreal biopsy on the left-hand side here. You can see how that was done because it was a posterior tumor, and that was considered the best way of getting the best yield of the tumor. I waited a long time for the results. The results were overall very positive. The tumor was disomy 3. I retained my chromosome 3. I retained BAP1. There wasn't enough material for any genetic testing, unfortunately. What the other factors that were looked at was that it was a mixed cell biopsy, and that also it had a very, very high levels of PRAME as well. And I don't know if PRAME has been discussed in the summit so far, but it is quite, I think, quite divisive in the medical community. Some believe that it has a lot of meaning and place a lot of weight on it, and others are in the sort of middle of the campground, undecided, want to see more results, more research, and others just don't think that is a big driver and focus more on things like chromosomes and BAP1. Anyway, so what that was that an overall positive result. There were a couple of things that perhaps, a bit mixed bag, but overall good. So the question was sort of making sense of all of this for me, where to from here? And I think the going through the diagnosis and treatment was one thing, but coming out the other side was another thing, because essentially my whole life had been shattered, and now I was picking up the pieces and picking up all these individual pieces of my life and trying to fix them back together and make sense of them. And I think one of the hardest parts was then going into this period of surveillance. And it felt to me as though the world had sort of moved on, but I hadn't. I was going through this process of scans and surveillance, and everyone said to me, "Oh, you look great. Your eye looks great. You must be, doing so well." But the reality was that actually the process afterwards was the heaviest part. And so although I looked okay, and to be honest with you, I actually didn't care how I looked. Of course, I was very happy to keep my eye. I also was having to now, I think, deal with the trauma of that process. And it was very lonely because as an eye cancer patient, you are treated as an eye patient, which means that you are lumped together with other people who are treated for other eye-related conditions like cataracts and macular degeneration and so on. You're not really treated like a cancer patient, which means that you are not, I didn't feel as though I was provided the access that other cancer patients receive when it comes to mental health support. Because unfortunately, in ocular melanoma, it's rare, it's random. When you go into hospital, you're probably going to be the only one that's being treated for cancer in that hospital and no one else. So what next? The good news is that the tumor shrunk quite quickly. As on the left-hand side here, you can see the ultrasound of the tumor. The image on the right-hand side shows the tumor pre-treatment, and on the left-hand side, I think it was 9 months after, and the thickness shrunk by 50%, which is brilliant. That's what we like to see. And then, of course, the surveillance. So that was 6 months for me under the wonderful care of Dr. Joshua at the King Hall Cancer Centre with MRI with contrast every 6 months. After the second set of scans, a small stable lesion was identified, but this time it was enhancing. And it was enhancing and in subsequent scans it continued to do so, but it didn't change in size or shape or any other factors. So it's considered benign until proven guilty. And as we know, the liver is a very dynamic organ and it can pop up all sorts of things. The key is obviously to monitor. Being so young, also there was the question of whether to start a family. My prognosis was good, but of course the fear of recurrence, the fact that there was no genetic material, the fact that a biopsy is not a fait accompli, it's not a done deal, meant that I really had to grapple with the question of whether to start a family. And also moving back to the UK where I was born and spending more time with my family and navigating a new healthcare system. The good news is that I have a 1-year-old baby boy. His name is Teddy and he's the love of my life. And I absolutely adore him. The photograph here on the left-hand side is me receiving an ultrasound of my liver whilst I was pregnant with him, I think 6 months pregnant at the time. So I moved to the UK in December. I think the biggest factor for me was that fear was really getting in the way of my life decisions. And I had to change my mindset from one of what if I die to what if I live? Because if I change my mindset to what if I live, then everything becomes so much more manageable in my life. I'm able to make decisions that fill me with joy and fulfill me. And allow me to lead a much more like fulsome life than one that is led by fear. I think that change of mindset was a big factor for me, and also communicating my needs with people around me to tell them when I was struggling or I was going through a difficult period, because we're not born with a cancer handbook. We don't know what the right things are to say to people, and I found people said sometimes the wrong things to me, and I found that very upsetting, and I had to go through this process of really accepting that, not being angry, but also communicating in a loving way and an open-minded way about the things that help and that don't help me. So now I'm in the UK. Unfortunately, my biopsy, because of the risk profile, has disqualified me from receiving surveillance scans. There's a new guidance protocol in the UK about liver surveillance and disomy 3, and also the combination, my age being young, means that I'm excluded. So I'm now trying to advocate for myself to receive the scans through the NHS, because privately, unfortunately, I'm unable to afford. I've considered quite deeply the upside and the downside of not monitoring. The upside is that I don't go through the process every 6 months, and of course that brings up anxiety for me. But then at the same time, the downside is just too great. I can't hold my 1-year-old baby boy or consider having another child without knowing that I have a clean bit of health. And that downside is too big. So that's something that I'm really looking into at the moment and hoping to get an outcome on. And as Dr. Joshua mentioned earlier, I volunteer for the Victoria Cohen Eye Cancer Charitable Trust, which is a charity that raises funding for scholarships for aspiring ocular oncologists around the world. And recently we've awarded them to an ocular oncologist in Nigeria, in India, and so on. And I'll just leave you with this one Thai proverb, which is a bit random, but when the tide is high, the fish eat the ants, and when the tide is low, the ants eat the fish. And for me, what that means is that we never really know when we're at the peak or the trough of life. We don't know if we're at the top or the rock bottom. And things in life can change really slowly, or they can change really quickly. And you may be given with one hand, and then also life will take something from you at the same time. And I think that's probably the thing that I've learned from this process, is that life can change in a flash. And whilst ocular melanoma may not be the death of me, it probably won't be, because I have a good prognosis. It could be anything in life. I could have a freak accident. I could be 5-10 years, or I could end up being 100 years old and have many memories to share with my great grandchildren. And I think that is the big factor for me, was just was actually processing that, and having to build that resilience to ride those waves. So with that, I will finish.
Wow, thank you. That was super powerful, Georgia. Very, very much appreciate your insights, and that's quite a journey. I was going to defer to questions. There don't appear to be any in the chat right now, but please feel free to add some as we're just chatting before we wrap up. We've got sort of 10 minutes to do so. So I guess I'll start with a couple of questions, maybe to each of you before we wrap things up with Dr. Isaacs. So Georgia, there was that dissociation you talked about between being a cancer patient and being an eye patient. Is that, you think, a symptom of the healthcare system, or that there was a bit of dissociation between the two, and could things have been structured differently to offer you that support?
It's a good question. I think it's a combination of factors. I think one is healthcare system. You're treated within an eye care setting, and not within a cancer setting. And there are upsides and downsides to that. You don't want to be completely institutionalized into this like cancer world where that really does, not allow you to move on with your life, if that makes sense. If it becomes a dominating factor for you. But then at the same time, in the eye hospital, I really was the only one at that point in time of that week receiving treatment for cancer. It would have been very nice to have been offered, or been made more aware of the resources that are available in Australia. But also I know this is the case also for friends that I've met in the UK. I think the other factor is that it is so rare, and so it sort of falls between the cracks in that sense. And you're either lumped as an eye patient, or potentially as cutaneous melanoma patient. So I think it's probably healthcare system, but also the rarity of it.
Right. There's some things I guess we can fix as healthcare professionals in that answer, some things we can't fix, but it's good to understand from your perspective where the pressure points are. There's a question: how can doctors better prepare patients during the surveillance period in terms of mental health support? And what forms do you think will be most helpful? Counseling or other things? Do you have any thoughts, advice?
I think I think everyone is so different. There are some people that this really actually creates, in some respects, and I respect some of the rationale behind not providing scans for low risk patients in the UK, because it could actually create unnecessary stress for them, or anxiety. But actually that might be the case for some people, and they decide and fairly enough to not opt in for surveillance, and that's their decision. But then there are some people who they do want to, but it fills them with lots of anxiety. And I think, yes, I think probably more awareness raising of the medical community, of the support networks that are available for ocular melanoma patients, whether there is a melanoma counsellor at the Melanoma Institute. There's Ocumel UK over in UK. There's Ocumel over in Australia and New Zealand, which is run by the wonderful Susan Vine. There are resources, and I think one of the factors is probably loneliness and speaking with people who understand. And in those patient forums, you can share some of your deepest fears with people, and they can listen openly and without any kind of any other predisposition. So yeah, I think more awareness raising of what's actually already available as opposed to creating more. I think that link is not quite there. For me personally, I feel anxious, but I see it as like a green slip. It's like my MOT. I go in, I get my checks done, and great, I'm on my merry way. I know that there's no evidence of disease, and it allows me actually to live my life in more confidence.
Great. And Joe, maybe just talk us through, I don't know, there's in Australia in terms of liver-directed therapies, I must say we're probably a little bit behind the 8 ball. We do intrahepatic photomustine, intrahepatic Surspheres, but nothing fancy like you've just described, either with the Heptazo kit or the Melphalan. How difficult was that to set up in a public healthcare system? The thought of that setting up a similar infrastructure here fills me with a sense of dread. We share similar limitations in the difference between our ability to want to help patients and the ability of the system to do so. Do you have any advice?
I wish I did, but we actually have less access than you currently on NHS, and that the only access to Delcath is through private self-funding, basically. If one or two of the insurance companies, and those people who are lucky enough to have insurance, can get it funded, but most of the insurance companies don't fund it as yet. So we had focused clinical trial, we had some compassionate use access to Delcath in the early years, and then we have those people who can raise money, and people are incredibly generous. So we've actually had a number of people who've had GoFundMe pages and so on to get access to it. It's currently going through the system with specialist commissioning, so we hope it will lead to us being able to deliver PHP more equitably across the country, and I hope the evidence will support that. And really, as we've discussed, providing that real world data to support the benefit of PHP, I think will be important in that discussion. In terms of setting it up and at an institutional level, it isn't easy. And it's one of those things where it needs engagement from not one discipline, but it needs a driver also at least from IR or from anesthetics. So you've got other interested individuals, because it's a lot of moving parts, and it requires a lot of pushing, and I think that's partly been why it's never picked up internationally, is that it's needed lots of people involved, but it can be done. And I think the data from Focus, if anything, undersell the benefits of the treatment. When you look at the series, the response rates are higher. Anecdotally, responses and benefits seem to be excess of what was shown in Focus. So I think it's worthwhile doing. In terms of the other liver-directed therapies, we've only ever had little access here and there when we've had IR getting free samples of cert or whatever. And I think that's going to remain the case in the UK because we're very much driven by having randomized data and in particular survival showing that there is benefit to the treatment, and we just don't have that for the other treatments as yet.
Great. We will thank you both for your time in this last session. I will now be joined by Dr. Isaacs. And just to close out the meeting, from my point of view, I just wanted to say thank you to a number of people. So firstly, Dr. Isaacs for driving forward a Western Australian-centric AOMA meeting. So taking up the baton for the year, and we have had a great range of speakers from Perth, I think, that's really highlighted all the work you guys do out west, and that's certainly been very much appreciated, and we'll turn the baton, I think it's probably back to the East Coast for next year's meeting, but it's been very nice to rotate the focus of the meeting from city to city around the country over the sort of 5-year cycle that we do. So that's great. So Tim, thank you very much to you and your team. Thank you very much to Merrin, and Gabrielle, who organised things from the AOMA point of view, and to Rania Poulos, who's been in the back end organising all the stuff from the meeting makers. If anyone needs her details, I'm sure AOMA will be able to pass it on. This is all, looks very nice on the screen, but there's an immense team behind the screen that are making this all happen, coordinating everything, and we're very grateful for her help as well as the company. We also have to thank our sponsors, without whom this meeting would not have happened. So that the platinum sponsor is Medison, gold sponsor Idea Biosciences, you've heard from both of them today, and our bronze sponsors, University of Sydney Safe Site Institute and Eckert and Ziegler, who make the plaques actually. So we very much appreciate their support. Hopefully in years ahead, we'll have more treatments and more sponsors, but this has been an excellent start. And I think we all get the feeling there's an incredible momentum in the field that is hopefully going to reach fruition for everyone globally. We look forward to sort of, I think these talks will all go up on the AOMA website. We're available. And finally, we do encourage everyone to make a donation if you can. So, Tim, any thing you want to add?
Oh, well, thank you, Anthony. I really just wanted to thank you for the opportunity to give us in WA the opportunity to share, some of what we do over here. We do feel quite isolated from the rest of the country at times. I think really I would just particularly like to pay tribute to the patients who've agreed to speak to us today. Not only have they been forced to go through this very difficult pathway through really no fault of their own, but they've had the courage to share their stories with us. So a particular shout out to Melody, Kelly, Anne, Ileana, and Georgia. I think you've all really given us a very good insight into what you've gone through, and I'm sorry you've had to do this, but I think your generosity and courage would be an inspiration to anyone who listens to this. So thank you. I'd also just like to thank Merrin and Rania for all of their help in organising the sessions. They've been brilliant. If you need an organising committee, they've been fantastic. So thank you to them as well.
Right, and thank you all very much. I don't know how many people are online. I do know there's 121 people online at the moment. So all 121 of you, thank you very much for taking the time out to listen and sticking it out to the end. Very much appreciated. If there's any questions or any suggestions for next year's meeting, please, maybe we can put the contact slide back up. Email them through to AOMA through the webpage. We very much appreciate you all taking the time, and thank you, and have a nice evening.
Thanks, Anthony.
Thank you.